pleasure to introduce Dr. SHEETAL BRAR, who is a Senior Consultant Phaco-Refractive at Netadama Eye Hospital, and she was my fellow, and she will be speaking on post-refractive surgery IOL power calculation, which is a very important topic because you have more and more patients coming with post-refractive surgery having cataracts. Over to you, Dr.
Thank you so much, sir, and thanks for making me part of this prestigious course. Dear friends, I'll be talking about post-refractive surgery IOL power calculation. It's a little theoretical talk, so kindly bear with me. So I'll directly go to the three main types of errors that cause problems in IOL calculation post-LASIK. So first error is the instrument error, second error is the refractive index error, and finally we have the formula error, or also known as the ELP error. So instrument error, basically when you use keratometer, the problem with using keratometers in post-LASIK cases is that the keratometers measure the paracentral points at 3.2 millimeter zones and they miss the central flatter zone. So now the maximum change in the corneal curvature occurs in the center due to the refractive surgery, be it any type of refractive surgery. So the central data is actually extrapolated and it is not accurately measured, and the power is overestimated and it leads to a hyperopic shift. So this is instrument error. Refractive index error basically is, again, when you use keratometers or even topographers, the SIMK values, the problem is that they use the fixed or the standard refractive index of the cornea, that is 1.337, which is actually not the exact, not the accurate, the real refractive index of the cornea, which is 1.376. Now this fixed or the standard refractive index is used in most of the keratometers or topographers because it allows for the for the contribution of the posterior surface, which is the negative surface, and because we know that there is a contribution of the posterior surface to the total corneal power, so this has been kind of made a standard refractive index that is used in most of the keratometers. But again, after refractive surgery, as as the ratio of anterior and posterior curvatures changes, this refractive index does not hold good. So you cannot use this, and you will have to use different methods that measure the corneal power accurately. So by this error itself, there can be an overestimation of the corneal power by 1 diopter per 7 diopters of refractive correction, leading to a hyperopic shift. Finally, we have the formula or the ELP error. Now, why this occurs? Again, due to a change in the corneal curvature. Now, the corneal curvature changes, so also the effective lens position changes. Now, we have problems with measurement of the corneal curvature, hence the estimation of the effective lens position also changes, and 1 millimeter error in effective lens position can actually lead to a 1.5 diopters change in the final refraction, which is very significant. So the problem of using third generation formulae in this scenario is that these are two variable formulae using keratometry and axial lens. So since our keratometry is not accurate, we are bound to have errors in the final IOL calculation. So then how do we measure the true corneal power after refractive surgery? So there are different methods. I'm not going into the complete detail of these methods. The first one is the clinical history method, still known as the gold standard method. The advantage is that it is easy to calculate. However, a disadvantage is that you need a very, very accurate data and it is not suitable for post-RKIs. Then you have the contact lens over refraction method, wherein the power is calculated as the sum of the contact lens base power plus power of the contact lens and over refraction minus the spherical equivalent of the manifest refraction without a contact lens. So again, this is a widely used method, inexpensive. However, accuracy of the method worsens with the poorer visual acuity and hence is not suitable for denser cataracts. Topography based post LASIK adjusted keratometry is a better way of measuring post-op keratometry because it uses a single central post-op reading on the topography, and then this reading can be used in different regression based formulae on LASIK, the Koch and Wang formula and the Sharma's formula. However, this is not useful for post-RK eyes. Then we have the central ring topography method. This is the method which is used for post-RK eyes. So here you average the topographic corneal power of the central 3 mm area, and after applying this you can use it with the double K formula and achieve a good IOL predictability. And finally, we have the net corneal power measurements using both the data from anterior and posterior surfaces. So you can use Pentacam or Sirius or any other shine flux based device that measures the posterior curvature more accurately. With Pentacam you get true net power. This can also be used. And now we also have OCT based systems which measure the total corneal power more accurately, such as the MS39. Now coming to the different formulae that can be used in post-refractive surgery eyes. So a very popular formula is the double K Aramberry formula, wherein the post-refractive surgery corneal power is used to calculate the vergence or the IOL power calculation, and the pre-refractive surgery corneal power is used for the ELP prediction. And using this you can use the adjustment tables for the different 3-generation formulae and get better results. Then we have the Hofer formula, which is less sensitive to power variation, introduces less error in the post-refractive surgery eyes, and if the double K formula not available, single K Hofer Q formula may also be used. So another popular formula is the Hagee's ELP formula, which is already incorporated in the IOL Master 700. It is a regression based formula based on statistics, and this is also a LASIK formula, not used for cannot be used for post-RK eyes. Musket formula is another formula. This adjusts the power of the IOL using post-op measured data using knowledge of the surgically induced refractive change. Now all these formulas are there, but currently I would say the introduction of online calculators has made our life very easy, and they have shown to give very predictable and fairly accurate results. So the very popular online formula is the ASCRS website formula. ASCRS website, where you have post LVC as well as post RK IOL calculators. Post LVC IOL calculator is available at www.ilab.com. Hofer program website is also available at hoferprograms.com, and IOL master reference is available at drhill.com. So this is the ASCRS online formula, which actually considers the refraction. Even if you don't have a pre-LASIK data, it still works. So you just need to put the refraction, and there are different topography systems that can be used along with this, and even the OCT based systems. I think one of the most popular formula is the Barrett True K formula for post myopic and hyperopic LASIK eyes. This can also be used for post RK eyes, and this is based on the universal 2 formula and calculates a modified keratometry value for post refractive surgery eyes. Then we also use Holiday EKR detailed report, where you have the equivalent keratometry values from zone 1 millimeter to 7 millimeters, and what you use is the 4.5 millimeters values of keratometry and key them into the Holiday 2 formula. So this is another method that works quite well. And now, of course, we have total keratometry. Dr. Shreyas, Dr. Sri Ganesh have already discussed this, so I will not go into details. Basically, it measures the complete, the total corneal power of the cornea after refractive surgery. And now we also have True K TK formula, wherein the Barrett True K formula is also also takes into consideration the total keratometry. Hence, the results are even better. We also have ray tracing. We use MS39 for IOL power calculations. So this is also a very predictable way of IOL calculation post LASIK. So just ending my talk with one case of post SMILE. This was a patient, 47-year-old male, who had myopic refractive surgery 3 years ago, developed cataract and presented for cataract surgery. This is the Pentacam. You can see there's still some amount of flattening there, and the Holiday EKR report shows a fairly regular single spike. So in the corneal hyperabrasions, they are slightly on the higher side, so we did not opt for a multifocal in this patient, and we opted for a monofocal Zeiss CT Lucia lens. And then you can see that in this table, the first three methods are the third generation formulae, and the last five are the latest generation post-LASIK formulae, and you can already see that there is a difference of 1 diopter between the two. So the lens implanted was plus 22.5 as suggested by most of the modern formulae, and the post-op refraction achieved was 0.25 diopters, and using this post-op refraction we found the prediction errors, and you can already see here that the first three formulas, the prediction error is on the higher side, and it's more than almost 0.5 and above, and all the newer generation formulae have actually given us prediction errors within 0.5, and the best one looks like the Barrett Truque TK. So in conclusion, in post-refractive cases, always use more than one method to measure corneal power, use more than one formula and look at the agreement between them. Better to hedge in the direction of myopic results if it's a myopic LASIK, or slightly hyperopic or emmetropia if it's a post-hyperopic LASIK. Total keratometry based formulae appear to give better results. However, we need long-term data and more studies. However, patients should always be warned about the potential need of refractive correction after cataract surgery, so that they are not disappointed at the end of the surgery. Thank you so much for your kind attention.
Thank you very much. I think we have exceeded our time, and I would like to thank all my co-instructors, Dr. Shreyas, Dr. Sheetal, Dr. Supriya, Dr. Gaurav, and Dr. Jagatram. And I would like to thank the audience for staying with us till the end of the session and for the interaction.